Start. Pink of health, anemia, and IUGR. In the normal cycle, iron cycle, 1 to 2 grams of iron is absorbed every day, and about 1 to 2 grams of iron is excreted. The iron is used for formation of myoglobin in the muscles, in the form of ferritin in the liver, in the form of erythrocytes in the bloodstream. Next. The iron need during pregnancy in the first trimester due to cessation of menses, there is a very reduced necessity of iron. So in the first trimester, only folic acid is given to the girls. In the second trimester, that is the first day of the menses to the 12 weeks is the first trimester. In this trimester, there is no extra need of iron. From 12 weeks to 24 weeks, there is an increased requirement of iron, and because there is an increase in the plasma volume and about 45% increase in the demand of iron. And in the third trimester, that is 24 weeks to 37 or 40 weeks, there is an increase in the demand of iron by the fetus, and that is why the iron uh, uh, is given to pregnant women from the second trimester onwards. In the first trimester, only folic acid is given. Anemia. It's a condition of low circulating hemoglobin. Anemia among pregnant women is a serious health concern because the oxygen carrying capacity of the woman is reduced. And because of the reduced oxygen carrying capacity, there is a shrinkage in the size of the baby, and also the woman cannot enjoy her pregnancy because she feels very, very tired. She might get spells of dizziness, and also in very, very rare conditions, sometimes there is a death of the fetus because of anemia. So we should avoid anemia. The WHO definition is anemia in pregnancy as hemoglobin concentration below 11 grams per deciliter, and the Centers for Disease Control has a classification where anemia is less than 11 grams per deciliter in the first and third trimester and less than 10.5 grams per deciliter in the second trimester. To prevent this, we are now trying to achieve a hemoglobin of 12. Bara bara. From 12 years of age, we want all girls to have a hemoglobin of 12. So there should be no anemia in India. Prevalence of anemia in pregnancy. According to WHO, about 32.4 million pregnant women suffer from anemia worldwide. In India, 54% of women in rural and 46% of women in urban areas are anemic. 50% cases of anemia are attributable to iron deficiency anemia. How to overcome anemia? Erythropoiesis in pregnancy. Various factors are required for erythropoiesis: proteins, minerals, trace elements including zinc, cobalt, copper, vitamins, particularly folic acid, vitamin B12, vitamin C, pyridoxine, and riboflavin, hormones, androgens, and thyroxine. Severity of anemia. Mild anemia is a hemoglobin of 10 to 10.9. Moderate anemia is a hemoglobin of 7 to 10. Severe anemia is hemoglobin less than 7. Very severe decompensated anemia is hemoglobin less than 4. When the hemoglobin is less than 7 or less than 4, we see intrauterine fetal death. Iron deficiency anemia is the commonest type of anemia in pregnancy. Serum ferritin of 15 mg per liter is associated with iron deficiency anemia. Iron deficiency anemia is characterized by microcytic red cells. Causes of iron deficiency anemia. Dietary habits. You should avoid junk food. Defective absorption. Because of eating junk food, you have sometimes amoebiasis in the stomach. Because of amoebiasis, the food doesn't get absorbed. During pregnancy, in the first trimester, many antibiotics cannot be given. Worm infestation. If there is worm infestation, the worms eat all the food. So there is no food going to the patient. To prevent this, we can deworm the patient after the first trimester. Multiple pregnancies. If there is more than one pregnancy, the requirement of iron is more. Low iron stores and iron loss. Iron loss can be because of piles where there is bleeding per rectum. Iron loss can be low iron stores can be because of a original deficiency. So we have to replenish the deficiency and then build the iron stores. Vitamin A deficiency because of wrong eating habits. Effects of anemia in pregnancy. Preterm labor, that is delivery before seventh month. Preeclampsia, that means convulsions, fits. Intercurrent infection, that means falling sick repeatedly. Cardiac failure, because the heart cannot function when there is anemia. Postpartum hemorrhage, excessive bleeding, because the clotting factors are deficient in the blood. Subinvolution, where the uterus does not shrink after the delivery, and that causes bleeding. Puerperal sepsis, excessive infection post delivery. Puerperal venous thrombosis, blood clots in the veins because of iron deficiency. Pulmonary embolism, sudden stop of breathing because of the blood going into the small blood vessels in the lungs. Failure of lactation, because there is no strength. The woman is not able to produce milk to feed her baby. Looking at all these effects, we should take care that there is no anemia in pregnancy. Effects of anemia in the pregnancy, in the fetal effects. Intrauterine growth retardation means the baby shrinks because of inadequate nutrition. Intrauterine death. Increased perinatal mortality means the small baby that is born to the anemic mother can fall sick repeatedly after birth, and that baby can have iron deficiency anemia. So to break the cycle, we should see that adolescents don't have iron deficiency anemia. What are the symptoms? In mild anemia, there are no symptoms. In moderate anemia, there is weakness, fatigue, exhaustion, loss of appetite, indigestion, giddiness, breathlessness. In severe anemia, there is palpitation. The pulse is very fast. Tachycardia, you can hear your beating. Breathlessness, you feel breathless when you climb upstairs. Increased cardiac output. Congestive heart failure. Generalized anasarca. There is swelling in the body. Pulmonary edema. The lungs are filled with water because of anemia. And that causes disturbance in breathing. Clinical features of iron deficiency anemia. There is pallor. The skin in the eyes looks light, it's white. The nails become white. The tongue shows a angry red, cherry-like, stomatitis, glossitis, chiliosis. There is swelling in the feet that is called edema. Hyperdynamic circulation, short systolic soft murmur. When we auscultate the chest, we hear the muffling of the blood in the heart, and fine crepitations in the lungs because of water in the lungs. Clinical features of iron deficiency anemia. Hemoglobin estimation, the reticulocyte, the hematocrit, blood indices, MCV, MCHC, serum ferritin, total iron binding capacity, transferrin saturation, serum ferritin. This is with the blood sample, peripheral blood smear. Bone marrow examination to see whether there is something wrong with the bone marrow. Stool examination to see whether the stool is having some extra, excretion of blood. Urine examination to see if there is any urine infection. Serum proteins in the urine, and to see whether there is enough protein in the body. So after knowing what is the cause of the anemia, you can treat the anemia. Iron deficiency anemia early in the third trimester is responsible for small for age gestational birth babies. How to prevent iron deficiency anemia? 12 by 12 initiative, that is, the hemoglobin should be 12 of every 12-year-old girl. Improvement of dietary habits, improving the bioavailability of food iron, iron supplementation of adolescent and non pregnant female, treatment of hookworm infestation, iron supplementation in pregnant women, food fortification, that is, adding iron to the foods that are generally eaten by the pregnant woman. Antenatal care. Also, we are thinking of taking care of amoebiasis by giving proper medicines before the girl is 12 years old. Daily iron and folic acid recommendations. The WHO prophylaxis says daily 60 milligram of iron and 400 microgram of folic acid should be given till term. During pregnancy, and daily 120 milligram of iron and 400 microgram is given, and postpartum daily 60 milligram and 400 microgram of folic acid for 3 months. By the MOHW, daily 100 milligram of iron and 500 microgram of folic acid should be given for 6 months prophylactically. And in mild anemia, 2 tablets of iron. In moderate anemia, intramuscular iron. And in severe anemia, IV sucrose, that is uh, iron carboxymaltose is given. And postpartum, daily 100 milligram of iron, 500 microgram of folic acid should be given for 6 months. Management of iron deficiency anemia. Oral iron therapy. Prophylactic iron therapy of 100 milligrams of elemental iron with zero point 0.5 milligram of folic acid. Deworming of all anemic patients. Treatment of anemia, 200 milligram of elemental iron and folate. The problem with iron is it is not easy to take. Sometimes there is nausea, there is vomiting, there are side effects. That is why it is sometimes recommended to give intravenous iron injections. Bivalent iron salts such as ferrous sulfate, ferrous fumarate are more widely used and are preferred over ferric iron preparations as recommended by the WHO. Characteristics of oral iron therapy should have 100 milligrams elemental iron. It's readily released in acidic and neutral pH, gastric and duodenal. Salt should be readily absorbed in the ferrous form. Infrequent side effects, should not have several therapeutic agents, and it should be cost effective. Classification of oral iron therapy, conventional preparations, that is elemental iron, ferrous sulfate 20%, ferrous sulfate dried 30%, ferrous fumarate 33%, ferrous gluconate 12%. This is distributed free of cost by the municipal hospitals. Ferrous ascorbate 12%, modified release preparations like iron chelate, ferrous bisglycinate, ferrous glycine sulfate, and sodium ferritate are available in the market. They don't have gastrointestinal side effects and they can be taken very easily by the patient. Iron polymaltose complex and carbonyl iron are injectable forms of iron which improve the hemoglobin rapidly over 15 days. Conventional preparations, ferrous sulfate is the oldest form of oral iron supplement. It is estimated absorption rate is 10 to 15%. Absorption is reduced by various ingredients like phytates, that is tea and coffee, polyphenols, calcium, tannins. So it is preferred to be given early in the morning on an empty stomach. Side effects of oral iron, as I said, nausea, vomiting, abdominal pain, constipation, diarrhea, dyspepsia, blackish discoloration of the stool. Reasons for failure in response to therapy, non compliance. Because of the side effects, they don't eat. Concomitant folic acid deficiency. Only iron is not sufficient. Along with iron, you need folic acid, you need B12, you need vitamin D for the iron absorption. Continuous loss of blood. Suppose they are worms or they are piles, bleeding hemorrhoids, then there is loss of blood. So, how much ever you add, it is going to drain. Coexisting infection in the intestines, like amoebiasis, where iron cannot get absorbed, faulty iron absorption, and inaccurate diagnosis. Sometimes the cause of the anemia could be a faulty hemoglobin. So, we should first find out the cause of the anemia and then treat. In case there is thalassemia, giving iron is not going to improve the hemoglobin. Deficiency like microcytic anemia, pyridoxine deficiency, should be diagnosed before starting an iron therapy. Limitations of conventional preparation. It is attacked by inhibitors, chelation, and then oxidation, and ferric ferric is converted to ferrous form and then absorbed by the duodenum. Only 10.4% is absorbed. Because of poor absorption by the conventional preparations, the hemoglobin does not rise soon. So the newer preparations that are in the market are better because they cause faster rise in hemoglobin. Limitations of conventional salts, as we saw, and so now there are newer oral iron preparations like carbonyl iron, ferrous ascorbate, iron polymaltose complex, ferrous bisglycinate, and sodium ferritate. Merits of the new preparations: outstanding GI tolerance. Because of better tolerance, the patients take it regularly. Very safe, no poisoning, even with more than 10 times dosage of iron. No food interactions, better absorption. Because the compliance is high, the acceptance is high, the hemoglobin is better. Modified release preparations, development of new formulations, prolonged, sustained, controlled release preparations, improve gastrointestinal tolerability, Fefol snapules, Fencordin CR, Orofor XT contain a polymeric complex surrounds ferrous ions, forming a matrix, controls the availability of ferrous ions to the individual sections of the gastrointestinal tract in conformity with their absorptive capacity. Ruby, तार बंद कर. Innovative sustained release technology, ferrous ascorbate embedded in HMC polymer matrix. Polymer particles are well swell and they get sustained release. 45% is released in 1 hour, and another 20% is released in the next 3 hours. Another 35% is released in the next 5 hours. So, absorption of the ferrous ions is in the intestine. There is no dissociation of ferric ion in the stomach, and there are no side effects. Ferrous ascorbate is a synthetic molecule of ascorbic acid and iron. Ascorbic acid enhances absorption of iron by converting to the ferric form to the ferrous form. Ferrous ascorbate is less easily oxidized than the ferric forms. Absorption of ferrous ascorbate averaged 52% higher than ferrous sulfate in subjects with iron deficiency. Advantage of ferrous ascorbate over conventional ions: it is more stable, there is no discomfort, there is no discoloration of the stool, and because of the high absorption of 67%, there is better correction of anemia and there is better compliance by the patients. Ferrous glycine sulfate and ferrous bisglycinate. These are the newer iron preparations that are available in the market. They are amino acid chelated ions, irrespective of the pH. That is, irrespective whether you have eaten, you have not eaten, whether you have had calcium. In spite of that, the iron gets absorbed. Chelated ferrous bisglycinate avoids unwanted interactions with food ingredients. Carbonyl iron. It's a pure form of elemental iron, has low toxicity, it has very fine microsphere particles, it is better absorbed, and it has lesser GI side effects. It is available as modified release preparations. Sucrosomial ion. Innovative oral iron formulation in which ferric pyrophosphate is protected by a phospholipid bilayer plus a sequester matrix, sucrosome. It's absorbed through the paracellular and transcellular routes It has a high iron bioavailability and excellent GI tolerance. Parenteral iron therapy, that is injections. Many view the formula as inconvenient. It is consistently used in clinical practice. Although use of the Ganzoni formula is ideally the best way to select the dose, it is impractical partly because product labels state specific dosing regimes. In typical clinical practice, doses are more efficiently chosen based on approved product labels and local protocols. Only in iron dextran injection, prescribing information is a weight and hemoglobin based table available to calculate a patient's total iron requirement utilizing this formula. Iron dextran complex is given intramuscularly or intravenously. Iron sorbitol citrate only can be given intramuscularly. Jectofer. Iron sucrose complex, each ml has 20 mg of elemental iron. This is given intravenously with normal saline. Iron gluconate is available as sodium ferric gluconate. Parenteral iron preparations. Type 1 complex, strong, ferric carboxymaltose, iron also maltose, ferromoxetyl iron dextran. This is given intravenously with normal saline. Type 2 complex is moderately strong, iron sucrose. Type 3 complex is weak, ferric hydroxide and ferric gluconate. The most common preparation that we use is ferric carboxymaltose. It is has lesser side effects and is better tolerated, and hemoglobin rise is seen in 15 days. Iron sucrose advantages: no tissue peroxidation. Disadvantages: multiple infusions, less oxidative and parenchymal tissue injury, higher availability of iron for erythropoiesis, minimal side effects, less anaphylactic reactions, hemoglobin rise as early as 5 days. Disadvantages: multiple infusions, multiple visits, and longer duration of therapy, less but significant number of reactions. So, need of a step up where anaphylactic reactions can be handled. New intravenous ions, ferric carboxymaltose, parenteral iron therapy, non-dextrose containing drug with a near neutral pH, physiological osmolality. Colloidal solution of nanoparticles which consist of a polynuclear ion co-stabilized by carboxymaltose. Stability of the ferric carboxymaltose complex permits the administration of high doses of iron. It is expensive. 1000 milligram costs around 4500, but the effects are good. Ferric carboxymaltose has a relatively short half-life. Repeated administration of 500 or 1000 milligram of iron as FCM does not result in accumulation of iron in the serum. Based on extensive experience in clinical trial and real-world settings, ferric carboxymaltose is an effective and generally well-tolerated treatment for rapidly replenishing iron stores and correcting anemia in patients with iron deficiency of various etiologies, including patients with chronic kidney failure, irritable bowel syndrome, perioperative anemia, women with iron deficiency during pregnancy, postpartum, or associated with heavy uterine bleeding. Ferric carboxymaltose is the choice of iron preparation in the doctors of today. Just one or two transfusions are sufficient to correct the anemia. It has low antigenicity. Uh, an ideal iron preparation should have a low antigenicity. It should not require a test dose, and time for injection should be short. Iron dextrose has a high antigenicity. Test dose is required, and it takes 4 to 6 hours for 20 milligram per kg. Iron sucrose has a low antigenicity. Test dose is required, and it takes 15 minutes for 100 milligram. Ferric carboxymaltose has low antigenicity, no test dose is required, and 15 minutes for 1000 milligram of ferric FCM injection. So the best of all is ferric carboxymaltose because no test dose required and no side effects seen. Extensive studies across different indications include postpartum anemia, iron deficiency anemia due to abnormal uterine bleeding, chronic kidney disease, chronic heart failure, inflammatory bowel disease, pre and post uh, operative anemia. All these are the indications for ferric carboxymaltose, which we call FCM. In pregnancy less than 30 weeks, if there is iron deficiency anemia, folic acid deficiency or oral iron therapy can be given. Oral folate therapy can be given. If there is intolerance or non-compliance, intravenous or intramuscular iron can be given. When the pregnancy is 30 to 36 weeks and there is iron deficiency or folic acid deficiency, parenteral iron and oral folate therapy can be given. Intravenous iron or intramuscular iron. But when it is more than 36 weeks, there is no role of iron. You have to give blood transfusion. The only problem with blood transfusion is the triple H, that is HIV, HBsAg, HCV, is all done and then only the blood is stored. But there are certain window periods. That is why we avoid blood transfusion, and that is why we should not wait till 36 weeks to correct the anemia. We should correct the anemia at adolescence, so the girl child from 12 years of age should not suffer for anemia. Before marriage she should be healthy, after marriage she should be healthy, during childbirth she should be healthy, and post delivery also she should remain healthy with a hemoglobin of 12. That is our consensus for the year para bara. Thank you. It was wonderful.